Well, we'll start. Welcome, everybody. The Chiefs asked Frank and I a while ago to do a combined grand rounds, and so we thought the best way to do that would be to switch personalities and roles as part of that process. So some of the people who haven't been at Children's, you probably won't get the inside jokes on a lot of the data, but we'll give you the opportunity. So I'm going to start first with a little bit, just to review a little bit about motion analysis. That one. Frank and I have no financial disclosures. In fact, if you'd like to help us pay for drinks after this, we'll be happy to have you come and join us at Cedar Creek. So I'm going to talk a little bit about learning objective reviewing, normal gait, a little bit of history of gait, motion analysis. We're going to identify a few patterns, and then we'll go through some clinical conditions and kind of duplicate some of the Tuesday morning review sessions that we do as part of the program. So gait cycle has been very well studied, and you can see the nice part is that it's a repeated activity over and over again, so it gives you an opportunity, and you can use split screen video to do it, look from an analysis standpoint. Oops, I guess I have to wait until it's done. Nope. Gotta keep walking. What do I do? There it is. It's easier for me over here. I'll just run it off the computer. Okay. So the gait cycle. A gait cycle is from the heel strike on the, in this case, on the right heel. It goes all the way through, and the cycle is completed when it gets to heel strike again on the right side. There are some critical, and you can see this kind of shows you the cycle. It describes, again, initial heel contact, opposite foot off, and then looks at the cycle. So the things that we look at are a lot of the temporal events and the important instances in time. Obviously, the first and most important is the initial contact. The second is foot off from the opposite side. The time periods between the events, we have stance time. So this is when it stands, when the foot is on the ground. And then there's swing phase time, which is the about 40% of the gait cycle when you can see the limb is swinging. There's 2 periods of time where both feet are on the ground, unless you're a horse. And then those are called double support time, so you can see. And then there's single support time, which is the swing phase of the opposite side or the swing phase of the studied side. And we're looking at step time and stride time. It gets a little confusing to look at the ankle, and they're called rockers, and so there are a variety of ways of describing the first rocker is controlled plantar flexion. So that's when you basically lower your foot to the ground during weight acceptance. The second rocker is controlled tibial advancement, when you control the tibia over the ankle. And the third rocker is limits dorsiflexion and starts heel off. So that's during the swing phase. So you pivot at the ankle joint, and at this point, this is where you get a large power generation. The other things that we describe is step length, stride length, which is the complete stride or complete cycle, and then step width, which you can see is related to the side-to-side sway. And then the foot progression angle is about 10 to 14 degrees. This started a long time ago with Muybridge in 1878, where he started to look at and actually looked at the biomechanics and the running of horses and did that. And if you go to the Smithsonian, you can actually see his data that he used to do it to correct. And you can see, again, examples of the gait motion analysis that was at this point. The next group was Vern Inman. All those that have taken a prosthetics course have learned about the gait and all the activities that are related to the gait, particularly in regard to amputee gait and prosthetics. We had the opportunity, Frank and I and Jim Carollo, to put together a gait lab, and we now have the second gait lab, which is at Children's, and many of you have been over there to see, and you can see what we have. So the gait lab does biplane high-density video. We can do slow-motion movement analysis. It can look at temporal distance measures that we talked about before. It can do 3D kinematics, looking at joint angles, velocities, and accelerations. And you can do 3D motion kinetics, looking at ground reaction forces, movements, and powers. And there's an entire team that's used to help with this process. We can do dynamic EMG that's synchronized with the muscle activity. They use both surface and wire electrodes. And we put them on in a consistent fashion, following protocols, even though during a deposition today we were accused of not doing it that way and stuff. So, and we look at plantar pressures. And so you can see we have the operative. We use a Vicon system. We have Vertex force plates. We have wireless EMG. In the research lab, we have a split belt treadmill. We have a Robomedica body weight support. We have a oxygen consumption system, and then we have an isokinetic machine if people want to do that. And when patients go through and walk through that, we create this image, which is a polygon. And so what we're going to do today is present some cases that are dealing with the polygon. So you can see at the same time when we present these, you can see the split screen video. You can see all the kinematics of the body and the coronal, sagittal, and frontal plane. And then you can manipulate the skeleton so you can see and look at rotations, forces, angles of directions, etc. And so we thought we would present a few of the cases and similar that we do as part of the process. And for those that get the answers right, I have stamps available. I have Angry Birds and flags. So whoever gets the first answer correct, they get to come up and get a stamp.
So Dennis invited me to kind of share with going over these cases kind of like we do. Since I'm an orthopedic surgeon, I thought we would do this like the orthopedic educational conferences, which are 3 hours. So I hope you guys are good with that. We've prepared 87 cases to review with you guys. Maybe we can get through them by 8:30. So I'm sorry, this is Alexis Girk. She is my research assistant at Children's. She's done an awesome job putting these slides together. I think we should give Dennis a round of applause because this is the first time he's seen these slides. And he did an amazing job reading them. But so every Tuesday, Dr. Carollo, Dr. Matthews, myself, and a number of engineers, therapists, Susan Kanai here from the Gait Lab, also Wendy Lynn actually sits in frequently, video conferencing and I think Mike Pacharo is going to start coming down to the Gait Lab also. And we go through the cases that have come through the previous week. We display, we're not going to run Polygon, but we display, watch a video of the kids walking, and then we look at these graphs, and we can jump back and forth to the different screens to look at the data that we generate, and then we sit down and discuss the cases. And at the end of each case, we have a consensus on recommendations. We put those recommendations on paper and send them to the families. And then frequently they're surgical, but it involves braces, therapy, walking aids, whatever it takes to help the kids to be the best they can be. So I guess this is our first case. And
who wants to win the stamp? Diagnosis. You can have the stamp on your forehead or your belly button. You can have your choice. Or your mother's belly button.
The heel cord lengthening wasn't done at Children's Hospital, and he just showed up and came in complaining of knee pain. He didn't even know he had cerebral palsy. And he said, "My knees are really killing me. Is there anything you can do for us?"
Okay, who wants to make the diagnosis? Talk about the gait. What's the gait abnormality? Aaron? Yay! Come on up. What do you want?
So what Aaron said was correct. It's a crouch gait, and that's characterized by excessive knee flexion. And then we have these graphs here that we look at. The left-hand column are the sagittal graphs of pelvis, hip, knee, ankle, frontal view, pelvis, hip, knee, and then the foot progression is the alignment of the feet to the lab. And then the looking at them from the top, just look at rotation, so we can see if there's rotations of the femur, the tibia, and based on this, we usually make our decisions. And what really jumps out here is that the knee flexion extension curve, the gray bar is normal, age matched. The red line is the left leg. The green line is the right leg. The vertical line is foot off. And so everything to the left is stance. Everything to the right is swing. So typically you you hit with your knee extended. You flex your knee just a teeny bit to absorb some energy. And then you straighten out as you're advancing forward. And then you have to bend your knee to clear it for the next step. If you look at his graphs there, he has obviously excessive knee flexion. It stays flexed all the time. Probably didn't need the graphs to tell you that. But you can see also that his ankle is dorsiflexed too far, and his hip is flexed excessively also. Anybody want to give us a suggestion for a treatment? Since Dennis picked on Aaron, I get to pick on Lindsay, I guess. So you want to shorten the heel cord? Okay. That's not an easy thing to do, but brace him. Okay. So he has a fixed knee flexion contracture of about 45 degrees. So if you brace him, he will then walk on his toes. Yeah, so the guys from Children's know. For this one, there's been lots of different ways of trying to treat this over the years. When I first started, we would try to straighten the knee out by cutting the posterior capsule of the knee joint, straighten the knee out. But what happens? The leg gets longer, right? And the structures that are taking a shortcut are posteriorly, and so the neurovascular bundle gets stretched when you straighten the knee out, and then they get nerve pain, which really sucks, and they really hate you for about a year after that, and then after that year, they're stuck back in flexion again because they were more comfortable with the knee flex. So more recently, we're actually taking a piece of bone out, so we're actually shortening. We can actually go.
Yeah, we can show you.
Yeah.
Usually at this point, Frank's recommending Botox to the medial hamstrings.
Right. Yeah, don't you think? Botox to the hamstrings? Maybe Botox. I would do psoas, hamstrings, and anterior tib, I think. Okay, so I guess just advance them. Gravity is causing his, once your knees start to flex, gravity actually accentuates that. The ground reaction force is behind the knee joint. Typically, the hamstrings and the psoas are tight. The quad, glutes, and gastrocs are weak. This is sometimes an iatrogenic problem. If you lengthen the heel cord when they're cute, up on their toes when they're 5. When they get to be adults, they don't have enough power to then control their tibial advancement. And so, but you, go back. So if you correct it, then you can get the ground reaction force in front of the knee joint, and it's much less work to hold your knee extended than if it's behind and gravity's pulling you down. So what can you do non-operatively? You can strengthen weak muscles, do a little therapy, but trying to strengthen the glutes is pretty challenging. We can certainly support the ankle with an AFO, but strengthening the quads is frequently challenging, and the quads are typically stretched out and too long, so even if you had them strong enough, they frequently still have a quad lag. You can do dorsal but there's already a fixed deformity there. You're going to make them weaker. You can do back and fin, same problem. Botox probably isn't going to be enough. So then the surgery part, we do an extension osteotomy. I'll explain that to you. We do a patellar advancement to tighten up the quad, or we can do guided growth. If they're still growing, we can do shut down the anterior part of the distal femoral epiphysis, and as they grow, the leg will grow itself straight in the younger kids. Sometimes we lengthen the hamstring, not so much anymore. Sometimes they're stiff and we need to erect a femoris transfer. You're going to be able to answer all those questions when we get done. Lindsay said to shorten the Achilles tendon, and that could be an option, but it doesn't work very well. And sometimes we have to lengthen the psoas also. So the next one is the video, right? So this is just a quick video of the distal femoral extension osteotomy, where we take the knee starts off normal, obviously, but as they stay flexed for longer and longer periods of time, the posterior capsule gets tight, and then they can't extend. Eventually, they can no longer extend their knee joint completely. And so then we do an extension osteotomy, so we take a chunk of bone out. If you're an orthopedic surgeon, that's really cool. And then you sort of create a deformity so that you get full knee extension. Again, we do see some remodeling on the kids that grow, that are still growing. So this is that same patient where you can see we cut, this is pre-op. You can see also the patella looks a little fragmented. There's been so much tension on the quad with him walking like that the quad, it's like sitting Larson Johansson jumpers knee type situation, causes knee pain. So we typically remove that piece. We move the patella down. We take the piece out from the femur. This is kind of what it looks like post-op. I think it's the two sides. And this is his pre-post. So he's walking better. But if you look at his curves, they're still not perfect. But he was really happy. His knees didn't hurt anymore. I said, well, you need to come back in a year so we can take out your hardware. He said, no, I'm good, doc. See ya. And he was. We never saw him again after the surgery. He never came back for a follow-up after he was healed. But it could make a pretty dramatic difference. Okay, second case. Any of your fourth-year residents want to take a shot that have been through children's? Do we have any of the combined residents here? Combined rehab peds residents? Or? Hiding? What year are you? 3? Oh yeah, you've been through. I recognize you. What do you think? Okay, so Alexis is going to give us a little history. Did that help?
She what? Circumducts her left leg. Does it look stiff? Oh. What do you think it's called then? There you are. She wins a stamp.
And you can see the circumduction, that's her left leg, so it's not that great. It looks like, oh yeah, so she's abducting a little bit, the red line right in the center up here, hip abduction, so that's circumduction. So she's trying to do everything she can to clear. She's flexing her hip excessively. She's actually tilting her pelvis a little for clearance. And so we thought that she had a stiff knee gait, which is typically due to an overactive rectus femoris muscle. And, here's the circumduction right here where she's actually swinging her leg out. So I think we recommended a left rectus femoris transfer as the only intervention. And so what causes a stiff knee gait? We think it's an overactive rectus femoris. Rectus femoris is a two-joint muscle, tries to flex the hip and extend the knee. This is the normal rectus femoris activity. For the orthopedist here, the black bar is when the muscle is on, and when there's no black bar, the muscle is supposed to be off. You guys all know that, obviously. In CP, we see 3 different patterns for rectus femoris activity. The normal on the left, on the entire gait cycle, or for some reason they get a burst to maybe try to flex the hip during swing phase. So if your quad is firing during swing phase of gait, you're not going to be able to bend your knee. So actually this procedure was invented by orthopedic surgeons who actually were doing gait analysis and figured this out from the EMGs. And so we actually take the distal end of the rectus femoris, we detach it from the quad, we move it posteriorly and attach it to the medial hamstrings. You can also attach it to the lateral hamstrings. It doesn't seem like that makes too much difference. That gets rid of some of the extensor power, obviously, if you're taking away the offending muscle, and it converts the rectus from a knee extensor to a knee flexor. It may not actively actually do that, but we certainly can't change the brain programming, so at least we're taking away the extension attempt during swing phase. And so this is her after her rectus femoris transfer, and you can see on the left, pre-op, very stiff on the left, and the curve's almost back to normal here after the rectus femoris transfer, and she's walking a lot smoother. All right. And so this actually shows you some of the changes. Obviously, the knee change is what we were primarily looking for. And we were talking about some of the compensatory mechanisms. So hip flexion is more normalized. It's less excessive than prior. She's no longer lifting her pelvis, and she's no longer circumducting her foot. So we were correct in assuming that those were compensatory mechanisms. So the gait analysis is also really helpful for us for measuring our outcomes. And orthopedic surgeons are really good at doing 10 operations, and they never came back for follow-up, so they all did well. Well, it's very humbling if you actually measure things post-op. So it's great for, from an academic perspective as well. Okay, third case. Anybody want to describe the gait? So this kid is obviously toe walking on his right side. And on both sides. And you can see he's sort of his rockers are messed up, so he's got a reverse second rocker, and he's basically in plantar flexion all the time. He is also, if you look at his knee curve, the whole curve is compressed a little bit. That slope going up is important, and his knee extension isn't very good there at the terminal end of stance, and so that usually will respond to a hamstring lengthening. We don't do it a lot anymore, but we still do it some, and the compressed dynamic range is another indicator of a stiff knee gait pattern and that slope. We had EMG evidence also that he had some rectus overactivity, and so we recommended on this patient to lengthen his calf muscles. That's the bilateral strayers, to lengthen his hamstrings, and to transfer his rectus femoris muscle. And we should have a post-op here. I'm going to tell you about the surgery a little bit. First, this is the second time I've seen the slides. In the past, when Dennis and I started our careers, we were lengthening a lot of Achilles tendons, and we didn't understand the relationship of lengthening the tendon, shortening the muscle, and then what happened 10 years later when the patients gained weight. The muscle was shortened. They couldn't then generate enough actin-myosin bridges to generate power to control their tibia. So we used to lengthen the tendon, but we recommend not to do that anymore. And that impacts both the soleus and the gastroc. You guys know the Silver Skull test. You examine the ankle dorsiflexion with the knee extended and the knee flex, because when you flex the knee, you take away the gastroc tension because it's attached to the femur. And so we have different ways of lengthening the calf muscle, mainly at the level of the gastroc. And so I usually do a strayer procedure, and my cut is usually where the red line is there. So this is this kiddo post-op. He's got a much better ankle curve, and his knee curve is not perfect, but it also improved, and he certainly looks a little bit better walking. You want to talk about this one? So we see kids that walk on their toes, and it seems like, they're toe walkers, so it must be a tight gastroc. But there is a group of patients that have something called apparent equinus versus true equinus, and actually their calf muscle isn't tight, but their knee is flexed. Their calf is tight enough that they can't excessively dorsiflex, so they end up walking on their toes. If you guys want a break, you can all stand up, bend your knee, and hold your ankle fixed, and you can't. It's hard to get your foot flat on the ground, and so that's apparent equinus. The graphs really help us to determine if it's apparent equinus or true equinus by looking at the ankle curves and the knee curves. And so if we lengthen the Achilles tendon on that, that's actually putting that patient at more likely to develop a crouch gait later on, which is a much bigger intervention to reverse. So this is meant more for you guys meant more for my orthopedic colleagues than you guys. But it's important to recognize this also so you're not constantly Botoxing. Because, again, a lot of the physical therapists, not a lot, a few physical therapists don't understand that relationship either, and they keep trying to stretch the calf muscle. You know, if we keep Botoxing, we're just going to make the calf weaker and weaker, and we're not going to solve the underlying problem, which is at the knee. Right. So here are the same kid on the left and then another child on the right. They're about the same age, and it's true equinus on the left and apparent equinus on the right. And the crucial curves are the ankle and the knee curves. And so basically, apparent equinus, their knees are flexed all the time. In true equinus, typically their knee has a pretty normal knee curve. The blue line is representing what's normal for these patients. And then on a true equinus, the ankle is plantar flex, so the horizontal line is 0, and so the ankle is in plantar flexion all the time versus the apparent equinus where it's not nearly as much, although this one has a little bit.
And this is a really important concept because if you continually to treat the gastroc, which a lot of people do, you actually make these kids worse. You really need to concentrate on their hamstrings. So you can poison their hamstrings all you want, but do not poison their gastrocs.
Well, you can't pick up that they're flexing their knee when they're walking on a physical exam. And, I mean, we can certainly see that, like it probably dorsiflexes his ankle to about 0 with his knee extended and maybe 5 degrees, or maybe with the knee flex, or -5 and 0. But before, I would just assume, oh, shoot, that's just spasticity and tone, and he's getting a stretch response and popping up on his toes more. So the gait data, to me at least, helps a lot until you really recognize these patterns. Do they put any of these curves on the rehab boards? Not yet? Yes? Are they starting to? Okay, because they're starting to put some of this on the ortho boards now. Anyway, important thing to just be aware of. Okay, case number 4. You want to give a history? So I'm dressed like Dr. Matthews and supposed to act like him during the conference. And so my comment is, this is a number 2. Next case, time is money. Right? Aaron, you want to tell him what a number 2 is? Yeah, you can't save the world. So this one is being carried down the walkway, and no matter how much effort we put in, we're probably not going to make this kiddo an independent ambulator. And so we certainly will talk to the family. We're obviously a little bit kidding here, but we'll talk to the family. If they really want to do something, we might be able to help them by doing an extension osteotomy just to get the knee straight so they can do a standing pivot transfer. We're certainly not going to get her out of a walker. She's really weak also, so this one is a pretty difficult patient to make much of a difference on. We classify patients with cerebral palsy in the GMFCS 1 through 5. 1, they're in an independent ambulator. 5, they can't propel their own wheelchair. This is a 4+ probably. 3, they have some. 2, they have some challenges with uneven terrain. Stairs, need to use the rail. 3, they typically use a cane or a walk. Gait train, not a gait trainer, a walker. A 4 might use a gait trainer. This kid probably would be better in a gait trainer than hand-up walker. What's that? Yeah, put a pump in her to decrease some of that tone. But she may sink worse because it will make her weaker also. So.
Or a scooter.
Yeah, that's the other comment Dr. Matthews makes a lot. Get him a scooter next. So these graphs are really helpful for looking at the mechanics at the knee, ankle, hips. We can look at the trunk, but it treats the foot as a rigid body. And so basically the foot is a straight plane, but this foot is twisting in, supinating, adducting, and the adduction is reflected in the foot progression angle, but we don't have any way to measure that varus, hindfoot varus or valgus. And so we also use something called plantar pressures. And this is this young lady's plantar pressure. So she's putting the majority of her pressure on her first met head there, because, her fifth met head, because she's supinating, so she's in equino varus. So we had recommended for her to do this is an old slide, or old one, a left. We did do a TAL on her because she was relatively tight, and the hemis do not go into a crouch gait because they have one good side. And then we did a split posterior tibial tendon transfer. So we take half of the posterior tib tendon and we move it to the lateral side of the foot and hook it up to the Paradius brevis. And then she had a deformity of her foot, so we actually cut the foot on the medial lateral side, took a little bone out of the lateral side, moved it to the medial side, and straightened out the alignment of her foot. So the plantar pressures allow us to see where the pressure is occurring, and it's sort of color-coded, so the redder it is, the more pressure. And on this patient here, there's more pressure on the lateral border of her foot. And so this is a diagram. We split the posterior tib. We move half of it over laterally, hook it up to extensor brevis. And here's her pre-post. Obviously, we're showing you mainly cases that came out pretty well. We certainly have cases that don't come out as well, but you can see her ankle curve has improved significantly. Her foot progression angle is almost normal, and her plantar pressures are much better balanced. Okay, the foot can go the other way also, so it can go into valgus, and you guys all see these flat feet, I'm sure, in your practices, and so the longitudinal arch is collapsing on this kid on the right side, and so I call it the mushy foot. So it's a combination, but there's the arch, bunch of little bones connected together by a bunch of ligaments. So if the ligaments are stretchy, then the arch, it's much easier for it to collapse. And so if your foot is mushy, when you're trying to push yourself forward mechanically, if it's rigid, you're pushing yourself with all your power. If your foot is collapsing, then you're losing a lot of power, so it's much less efficient. Typical kids sometimes have some symptoms, but we typically don't treat them too much. The CP kids seem to have more of it, partly because the calf muscle is frequently tight, it's pulling the heel up, and that's causing a midfoot break. Plus, they're getting stretched all the time from all different parents and therapists, and if they're pushing on the forefoot, then they're actually accentuating this problem. And so you can, to treat it, if the calf is tight, you have to lengthen the calf, and then you can lengthen the calcaneus between the anterior and middle facets, and that's called an Evans calcaneal lengthening. You can also move the heel into more varus, and that's slide osteotomy. And then one of my friends in Delaware fuses the subtalar joint together for this problem. And then let's see, we've got, this is an example of this bone block. So we cut the bone right there, we stick it in right there, and you can see there's quite a bit better arch post-op. We robbed a little video YouTube off the internet, but it's not running, so we'll let that go. Give us a history. I don't remember this case. Oh, yeah, this is the same patient post-op, sorry. I go, that looks pretty good. We don't need to mess with that one. Okay, 81 more to go.
This is a 7-year-old female referred by rehab for analysis of her gait deformity. She was a twin, born at 34 weeks with twin-twin transfusion. She began walking at 13 months, has been in AFOs as long as she can remember. She has no prior injections or surgery. Mom reports seeing an increase in her adduction and internal rotation, greater on the left than the right.
So looking at her graphs, her knee curves are reasonable. Hip looks good. Pelvic alignment is okay. She's a little bit of plantar flexion on the left foot. Pelvic obliquity, all of those curves look reasonable. She's in-toeing on both sides, so you can see the foot progression angle is not in the gray bar. She's got a little bit of pelvic rotation. She's got some hip rotation. And so both of her femurs are internally rotated, and that probably explains her abnormal foot progression angle. So she has some femoral aneversion. And so our usual approach for that would be to rotate the femurs. But in growing kids, it's a moving target with CP. So if we corrected her at age 7, the in-toeing would probably recur. And so we, on this one, the recommendation would be the orthopedic surgeon would say no surgery, Botox the left calf to try to get that foot in a little bit better position, and just to explain to the family the in-toeing is not going to interfere with her function that much right now, although there is some tripping occasionally when the foot swings through and hits the other, the back of the other leg.
This patient then went to see Dr. Matthews, and he said no to Botox of the left gastroc. And instead just repeat a gait analysis in 1 year, and then we'll consider orthopedics intervention. So she came back 1 year later and still has not had any Botox or serial casting.
Looking at her curves now, nothing has changed very much. She still has femoral aneversion. She's still in-toeing, and her ankle dorsiflexion is worse.
And so that way you can treat her surgically rather than continually Botoxing her.
Okay, so what was done after this one?
Chose to continue with Botox to the left gastroc and left post-tib, and maybe the right gastroc, as well as bilateral stretching cast for a tight gastroc, and we'll continue to monitor the lower extremity rotations to consider orthopedic intervention in the future.
But still a little bit young.
So this is her third analysis. She had Botox injections to bilateral gastrocs, left post-tib, and left medial hamstrings in July, as well as Botox injections to the bilateral gastrocs, bilateral post-tib, and phenol injections to the left medial hamstrings in March of 2016. Child and mother report temporary benefit after the injections. The child reports difficulty walking on uneven surfaces playing kickball and running, and she wears bilateral solid two-stage AFOs.
So her left ankle is still a little bit tight. Her right is actually doing better. She's still in towing, but things have changed a little bit now. So it seems like she's turning in more on the left side than the right side, although she still has aneversion, but it looks like now she's externally rotating some in her shank, her tibia on the right side. So now she's 10, and so I think we recommended to do osteotomies of her femurs to turn them out, turn her left tibia, turn her right tibia in, and do a split posterior tib tendon transfer. I think this is the end of this story because the surgery schedule, but hasn't been done yet.
It isn't playing, but
there's usually thriller music to go with that.
After hours, the staff gets very creative. So we just wanted to give you a little bit of indication of how we use the Gait Lab and how we've really formed a team approach to the process. And those of you that have been over on Tuesday mornings get to see how we develop this kind of a team. It's pretty interesting over all the years, the 30-plus years we've worked together. We kind of even think alike now, so we can. But the Gait Lab really does give you lots of objective data, so you can make really good clinical decisions about how to best treat the kids. And so we just wanted to give you that experience and flavor. Those of you that in your adult practice, we certainly, if you have gait abnormalities that you want us to look at, we could certainly do that too as part of the process. So just gives you a better idea.
And Dr. Matthews will be happy to answer any questions now. All right. Well, thank you for. I was kidding about the 87 cases. And thank you again, Alexis, for preparing all these.